Today we have the three co-authors. So Çağlar will be presenting, and both Erhan and A will be answering to clarifying questions via the Q&A section on Zoom. Little information to increase interaction also for all participants. All participants are able to exchange via the chat also on a bilateral basis. If you want to share comments before asking questions, you are welcome to do so. And so today, as I said, we have Erhan, Artuc, Çağlar Özden, and Wang. Erhan and Çağlar have already made great contributions to the migration literature, both in terms of constructing database that a lot of us have been using, and by applying dynamic discrete choice model to modeling repeated migration decisions. So it's really a pleasure to have you with us today. Çağlar, the floor is yours for 45 minutes, and then we're going to have 15 minutes of Q&A at the end.
Okay. Well, thank you, guys. I know summer officially started now. It's July 1, so I appreciate everybody being here. So this is joint work with Erhan and Hey. Hey just defended his dissertation, so we're very proud of him. He's a doctor, and he's also open for, I mean, he has a job for a year, but in case anybody wants to hire a great economist, advertising for him now. All right, so the motivation. I'm gonna try to speak very fast because this is a complicated and big paper, took us quite a bit of time to write. But so the pandemic is the ultimate economic externality, right? Basically, people who are spreading it, especially in the case of COVID, the young people who are socializing, going to work, going to parties, are also the least likely to be impacted. Right? So it's the whole, everything, all the policy measures are aimed to kind of solve the externality problems. Now, you are seeing we all have become very familiar with the SRI models very quickly. And there, some of them incorporate the mobility of the people because that's how the pandemic spreads, right? So all of the actually policy interventions, one way or the other, are targeting to limit the mobility of the people. But these models have two shortcomings. And this is what, you know, for an economist, these are, for us at least, the puzzling and the bothersome part, that the mobility of the people is endogenous, especially for us who work on migration, okay? So when people move, there's a personal economic benefit because we get a higher wage or we get to visit beautiful cities, but there's a social cost because we spread the virus. So the policy interventions we're gonna have basically will try to weigh the social cost against the economic benefit, and then we're seeing it, all the unemployment and the decline in GDP. Now, what we are going to try to do is to write a really complicated model and try to solve it, and the model will have two components. We're going to be merging basically as an SRI model with an endogenous labor mobility model. And while we're doing that, these are the questions we try to answer. Basically, how the mobility impacts spread of the disease and vice versa. So there's the endogeneity of both of the processes. And what kind of policies impact the spread of the outbreak, labor mobility, and most importantly, welfare, because that's the ultimate trade-off we're going to be doing, the health versus economic outcomes. And the other important thing that we're going to be answering, especially this is extremely important in the context of the US, because healthcare policies or mobility restrictions are done at the state level. They're not at the federal level. This is a legal issue, but which implies a policy implemented by one state has positive and negative externalities on the other. So one can argue, and we will argue, that part of the disaster we are seeing in the US is stemming from that issue, that the states are not necessarily managing to coordinate their policies. And the externalities, whether positive or negative, are not internalized at the national level. So let's start with this. This is one of our maps. This is the mobility before COVID. One of the advantages of COVID, all this mobility data using especially cell phone data became publicly available. And you're seeing, this is interstate mobility. Our unit of observation is a state and how many people move from which state to which state. So give you an idea, look at the color code, right? Basically which states in California versus Wyoming, right? And you're seeing the color difference. And this is, oops, the infection death rates as of March 24. As you can see, I don't know if I'm hoping it's the color scheme is kind of quite the same, which states are darker and which states are lighter colored. So And this is our two figures that I'm going to get back frequently, how the outbreak occurred across states. The first figure is the number of states with positive cases. February 24 is a critical date for us. Also, that's the date when President Trump announced everything is under control and it's all going to die out within a couple of weeks. And then you know how it rapidly spread. As of now, I think the mortality is around 130,000 and over 2.6 million people, at least officially, infected. But one of the other things we're going to come at, R0, for those of you who are familiar with epidemiology literature, R0 and population density, this is one of the figures we're going to use in the model, and the data is highly correlated. Okay, so basically how densely populated the state is, or the city is, or whichever, determines and how fast the pandemic spreads. Now, all right. Now, the additional points that we want to capture, which is, again, everything is all about externalities, right? We're going to be modeling low and high risk people. Low risk people are basically young generally, but with no pre-existing conditions. And low risk people putting high risk people in danger is the first externality that the pandemic creates. And the second externality is that depending on the state conditions, whether if it is the population density or at what stage you are in the pandemic, or all these other factors, the policies you implement create spillovers across state boundaries. And that's the second externality. And the model and the simulations, the policy simulations we're going to run are aimed to basically capture these externalities so that we can design the kind of the nationally optimal policies. So it's a complicated model, so I'm going to jump to it really quickly, and here it is. So here are 3 states: New York, Virginia, Maryland. I live in Virginia. Maryland is north of DC, and New York is where the pandemic really had the biggest impact so far in the US. But the model and the simulations are based on 50 states. I'm just doing it a 3-state figure. So the mobility of the people, the way we model it is the following. People have 3 choices, and these are economic decisions they make. They can stay home, engage in home production, like working from home or retired or whatever you want to call it, right? They don't really interact with the society as much. They can go interact with a business in their home state, or they can move across states to go to another state and interact with a business. When they go to another state, there's a moving cost, mobility cost that is involved, right? Now, it turns into a discrete choice problem. The way we model it, you actually, for those of you familiar again, at the beginning of each period, each individual draws a random shock with each business, and the business are associated with different states, and then they choose which business they want to engage with, taking the mobility cost into account. We wanted to simplify the mobility decision and reflect the reality. 99.8% of the trips in the US are temporary. You go for a little bit and then you come back home. So you go, you interact during that period, you realize a payoff, pay the moving cost, and then return back. This is the agent in New York, or you can interact with a local business in New York. Again, there's a payoff, there's no mobility cost, or you stay home, right? So that's the mobility framework is, in relative terms, compared to other dynamic migration models, relatively simple. Actually, what you will see is in the absence of the pandemic, which creates the dynamic spillovers, this would be a static model. Every period you realize the shock, you go visit, you travel, then you come back. All right. That was the mobility, the economic component. The SRI model has the following transition stages in a sense. People can be of 4 different types. They're susceptible, which means they never got sick, but might get sick. Infected, they are sick and they're spreading it. And from the infection stage, either they recover and they will never get sick again. They now have built immunity, or they die, right? And these are all probabilistic events. Now, the susceptible people are high risk and low risk. We assume the movement, the transition from susceptible to infected is a probabilistic event. And that probability depends on the number of the infected people in the state you visit. So if you stay at home, it is a much, much lower probability. So that's one way of saving yourself, right? Social distancing. Or think of it this way, at the beginning of the pandemic, only on February 24, there were only 17 states with infection. So if you are from Maryland, which did not have an infection at that time, if you go to Virginia, which didn't have, you're not going to get infected. But going to New York increases your infection. But going to New York might be a higher economic outcome, and you would be willing to take the risk. Then it means if you catch the virus in New York, you bring it back to Maryland, right? So that's what creates the dynamic linkages over time. Now, so I mentioned how the process operates. It is in a sense, slightly non-standard discrete choice model. So the agents basically choosing the businesses I mentioned. Now, the businesses are critical here because that's you shutting down the business so the government can decide, which a lot of governments did, right, as part of the social distancing policies. Shutting down the business reduces the economic incentive to travel, whether within the state or across states. And that slows down the spread of the pandemic. But it also reduces, in our model, the economic benefits of mobility, okay? As I said, the choices are temporary, but the health transition is persistent, right? That's how the decisions of one period impacts the outcomes of another period. And the health transition, of course, depends on the choice of the individuals. And here, whether if you're a low risk or a high risk individual makes a big difference, as well as the government. So the governments can close down the businesses, which reduces the benefits of mobility, or they can increase the mobility cost, which again reduces the mobility. But we will see those two policies have different implications in terms of mortality outcomes as well as economic outcomes. All right. So the main innovation here is that the health out, as opposed to migration models where the frequency is not daily or weekly, which we look at annual data, for example, and most migration is semi-permanent or permanent. Here, it's a temporary migration, but the health outcome is an integral part of the welfare optimizing agents' decisions. The innovation over the SIRI models is that now we have made mobility endogenous. It is not a mechanical thing. It is not simply a parameter. It is a decision variable of the individual. And that's how the policy can work or fail. All right, so here is our Bellman equation. I don't know how much I need to go through it. This is the value. So this is the first box in the red is the surplus from the interaction with the business. Now, when you interact with a business, the surplus, some of it goes to the individual and some of it goes to the business, right? And that's why the state government of the business where the business is located also cares about the mobility restrictions because they get a shared surplus. This is the mobility cost. So this is the net term of going to visit business K in state J. And this is the health transition, this pie matrix. I'm going to talk about it a little bit more. And the health transition and the surplus are the two kind of the stochastic components of the decisions the individuals make, right? So the government, what the government can do is both change the epsilon here, that's the benefit, or change the cost to impact the mobility decisions, right? So this is the dynamic process, in a sense, that guides the decision. Okay. Now, of course, we cheat a little bit. We make certain distributional assumptions on the epsilon, so it leads to these really neat things. So the expected value, the new here is the parameter, which pretty much determines everything. And the choice-specific value then becomes a function of the number of businesses that are open, right? So when the governments implement shutting down the businesses, it affects the benefit here, or it affects the cost here. And then there is the health transition, which is the dynamic process. Okay, right? Now, the probability of travel then is given by remember the X is the choice specific value, given the probability distribution, the fresh distribution, this becomes the probability of travel of an agent of type S, health status H, going from state I to J, right? This is the function form. You're all familiar with these. This is the standard assumption we make. And the other transition matrix, other than the health, the probability, you know, the pi here, the health transition from being susceptible to infected to deceased or recovered, is also how the population in state I moves from period T to T+1, right? So how many susceptible, infected, recovered, dead people you had in state I in period T, and how many become in T+1, it is given by this matrix, right? So we have these two transition matrices, right? This is the health transition matrix. So these are the, you know, it's a 4x4 matrix. So this is the, if you are susceptible, this is the probability you stay susceptible. This is the probability, the second item. Pi S ij T12 is the probability you move to being infected. The second row is the probability if you are infected that you stay infected another period. We assume the mean duration is 2 weeks, 2 time periods. The probability that you recover and the probability that you die, right? If you are recovered, you always stay recovered. It's an absorbing state. And if you are dead, you stay dead, right? So the mu is we calibrate. I'm gonna go to that. This is the probability of infection, which is given by the number of infected people in that state as a share of the population. And this is the how many people move. So this is the numerator is the total number of the infected people in state J, and below is the population of J, and gamma is the R0 parameter. This is the probability of infection if you stay home. We assume it's going to be, assume it's 20% of the if you went out. And this is the probability of death. Now, this is critical, and the probability of death looks like this. Basically, we want to capture, we go back to the data, and we look at the number of basically the beds, intensive care beds in a state, and given the infection rate, how many people are dying, right? So this is this functional form here, where you see, is going to capture the congestion effect. A lot of the externality is basically is arising from that, right? The more people you get sick, the mortality rate also goes up. So by lowering the infection rate, you're actually lowering the mortality rate. We are flattening the curve. Now, let me talk about the data. This spent an inordinate amount of time finding all the data, putting everything together from many, many different sources. So we need, for example, the high-risk population ratios, which is both elderly and younger people with health conditions in each state. The initial infection levels, this is not necessarily the reported cases, but the predicted cases. There's a very nice Imperial College report on that. We collected data on the intensive care beds, the rate of hospitalization, mortality rates, which led us to this form. And let me go. And then the population density and the mobility data and all of those, right? For example, we need to find, I'm going to talk about how we solve it. It's not as easy solving the calibration. So these are the basic parameters. Remember, the time period is 1 week. So this is the discount factor. This is the alpha, how the businesses and the visiting individuals share the surplus. The 2 weeks is the duration of the symptom. This is if you're a low risk individual, this is according to CDC, the mortality rate. And this is the mortality rate of a high risk individual. I mean, it might not be necessarily, we need to calibrate a little bit more, but it gives you an idea. And this is if you cannot get a bed, and if you're a high risk person, this is the mortality rate. And this is if you're a high risk person and if you catch the COVID virus, this is the chance of showing severe symptoms, okay? This is the average number of beds, and this is the infection rate, 20% of the actual if you went out. All right. Here is for example, the data at the state level. Now, simulation is not straightforward because it is a really, really complicated model. So what we have done, for those of you who know the trade literature, there is the hat algebra method, where you basically solve the outcome. You find the solution via the changes, not at the levels. Now, this is slightly more complicated because it's a dynamic model. There's a very nice recent paper by Caliendo and authors. I think it was an Econometrica paper, which they solve it in the Chinese trade shock context, what happens to the labor outcomes in the US. And Erhan and his co-authors apply this to the Brazilian case where there's endogeneity in the transition probability. Okay, so we basically are using this, and there are a couple innovations that, or a couple other challenges we had to solve here. So you do everything in basically in changes, right? So this is the change. Remember the X, the per period payoff. This was the X, how you calculate it. This is the expected value. And this is the N, the change in N is the change in the number of businesses. So you can solve the whole thing by looking at you collect the pre-COVID data and you look at the changes based on that. And assuming the mobility costs, for example, have not changed, for example, you do not need to calculate the mobility costs. You can look at the mobility level, which we did. The figure I showed you was the pre-COVID mobility. We can base on that. So let me show this here. So if we have here, this is the MIJ0 is period 0 mobility from state I to state J for type S. This, if we have that from the data. Based on that, if we have that, then we can calculate the mobility afterwards. And then we look at the, and then we have the changes in the businesses become basically the policy parameter. And then we have the probability, the health transition matrix, right? Which we calibrated based on the mortality and the infection rates, right? It still is complicated. It takes quite a bit of computation power, but it leads to a relatively decent solution time and really nice outcomes. So what we do is in period 0, before when the agents make their decisions about whether they should visit Colorado from California, there's no infection. But when they go to Colorado or they go to Washington State, they are met with the infection. So that is the shock. The initial infection on February 24, which we assume existed in 17 states, but not in the other. We'd have 49 geographic units. We exclude Hawaii and Alaska, but include Washington, D.C. So the other 32 states did not have an infection. And that initial shock in period 0, when the agents traveled to those 17 states and some of them caught the pandemic and brought it back home, is how it all started. From then on, but the people realize they are infected, and then they know what the infection rates are in each state, and then they make their mobility decisions based on that, right? So the only uncertainty about the infection is there. Of course, there is the uncertainty whether if you're going to catch it or not, but people have they know the probability of catching the infection if they visit a given state. All right, so this is what it looks like, the simulation. This is the case where we assume there's no intervention, right? The government followed, let's say, which would be the example, maybe the British example at the beginning, right? And they do not impose any policy restrictions. People go on their business. Of course, now, remember there are the high-risk people and the low-risk people, and on average around, according to the Center for Disease Control, as I remember, around 30% of the people are considered high-risk. So this is the infection rate of the high-risk and the low-risk people, right? The low-risk people, basically the dotted line, they get infected right away because they know the trade-off is okay. They're willing to take the risk, and they get infected right away. And the mortality is very low. This is 0.35%, as you're seeing in the bottom right figure. The high-risk people, on the other hand, right, the infection process is much more muted because they're going to take actions. And the action is shown here. Oh, by the way, although at period 0, remember, New York has an infection and the other states do not. This is the overall average for the US. There's pretty much no difference everywhere else versus New York, whether if you were the first state to get infected or not, it has no impact. It spreads pretty rapidly, and the process is almost identical everywhere, okay? But this is the mobility decisions of the people, right? The low-risk people, without any intervention, there is slight change in how many of them stay at home, but they go on their own business, right? There's no change in behavior. The high-risk people, basically, at the moment when the infection becomes high enough, that the risk of catching the infection and hence dying is high enough, they start staying at home. And then they stay at home for a while, and then staying at home also implies they never visit local businesses or they never go to other states. They visit for almost 10 time periods, or I think it was 12 time periods, and then they go back when the infection has come down. But they still remember, they still get infected in relatively high numbers, and on average, 2.5 or 2.7% mortality we're going to observe. Now, this is still, quite a bit of work in progress. Don't take the numbers take the numbers, don't believe the numbers necessarily, but the qualitative pattern is the critical one, right? Now, we're gonna...
Sorry, can I ask a simple question? So if you
Please.
get infected, you are immediately aware that you are infected, or you might not realize?
Yes. You are. No, we assume you are infected, but the government doesn't know. Other people do not know because you might be asymptomatic, but you do know you're infected.
Okay, thanks.
Okay, yeah. So there are two basic policies. I mentioned this early. One of them, the governments can restrict mobility, and we're going to assume 20 weeks, right? You can change the duration. You're going to see changing duration in many cases do not make a big difference other than pushing it down the road, because the moment you move the mobility restriction, it comes back. It might give you time. We didn't explore this. This is one thing we're going to do, because you can solve the supply chain problems regarding masks, or you give the vaccine enough time to be developed, right? Or the other policy, you can restrict mobility of the top 10 infected states, okay? The ones with the highest level of infections. Policy 3 and 4 is moving on the benefits of mobility, so you close the businesses for 10 weeks, or the other, the policy 3 is you close businesses in every state, or you close it in the top 10 infected states. Now let's see what the outcomes look like. So policy, I'm going to look at policy 1, where we restrict mobility. Again, this is relatively hard. I was mentioning it before we started the presentation. New York State just said if you're coming from the top 10 current infection booming states, mostly in the South, to New York, you have to quarantine yourself for 2 weeks. But this is not really enforceable. It is more on the self-enforcement side. This is really hard in the US. There's a constitutional, actually, ban against restricting interstate trade, right? Whereas in the case of China, the Chinese government acted when it became obvious where this was heading decisively and immediately banned mobility, right? It is much more easily enforceable in certain countries, definitely not in the US. In the European context, countries still, most of them are the size of the US individual states, they can control their borders. Here, New York does not necessarily have control over its own borders, but I'm going to present it anyway, assume it is, right? The one assumption we're going to make, so we're running some simulations based on this, the underlying infection spread parameter gamma is the same. There is now evidence that's also changing. People are becoming more conscientious, whether you're wearing a mask, you're not hugging everybody you see on the street, all that stuff. So what happens in reality, along with the policies, the gamma actually goes down as well, right? So the overall R0 is a function of the policies, the overall infection level, as well as the underlying structural parameter gamma. We're going to assume for now gamma stays the same, so we can focus on the impact of the government policy, right? All right, so let's go. Oh, this is the New York rule, basically says you have to quarantine yourself, but I know all these people who went and came from New York, nobody really did it. Okay, all right. So this is what happens in New York. When you isolate all states for 20 weeks, cut off travel, it has basically no impact because New York was already infected, right? This is the death and this is the infection. No change, all marginal change, okay? This is for the high-risk people because the low-risk people is not the concern here. This is what happens in Maryland. Do you see? It has two effects One is Maryland was not infected. You push the infection down the road, but it picks up when it comes back. Now, the peak is much lower because now there are fewer people actually infected in New York, right? So the chance of catching the disease is lower, and hence, as you're seeing, the mortality is lower, right? It brings it down. Closing down the borders for 20 weeks lowers the mortality by almost 1/3 at the end of the day in the basically non-infected states. It doesn't solve the problem. And this is what happens in the US. You are seeing it flattens the curve considerably, okay? And the overall mortality for the US. Now, unfortunately, the highly infected states, the initial 17 were the large states, right? These were the states like California and New York. So that's why the impact on the overall mortality in the US is much lower, but there's an impact. Now, look at mobility, the low risk people, you ban it, you know, they stay home, they don't go to other states. They don't stay home, they visit other businesses in their home state, that's the middle one, right? But this is what happens to the New Yorkers, okay? Basically, even the high risk people in New York, the share of staying home doesn't change. They substitute traveling to Pennsylvania and Massachusetts with traveling and visiting local businesses in New York. That is the reason why when you look at New York, the overall infection and the mortality did not change. You basically replaced businesses in other states with businesses in New York, okay? But in Maryland, there's a big difference. The behavior of the low risk people is the same, but the high risk people, you're actually finding, this is why the model is complicated, interesting dynamics, right? Look at the interstate, the last figure on the top. The high risk people, yes, they don't go to other states, but when it opens up, there's a jump, okay? Because there was lower reflections. In a sense, they have to make up for the lost time. That is, in a sense, what we are seeing today, the jump in the infection when they remove the mobility restrictions in Texas and in Florida and even in California is kind of a reflection, is the same phenomena. You're making up for the lockup, okay? And if you look at the US as a whole, this is what you see. Staying home changes a little bit, and then when the mobility restriction is lowered, it goes back up, but not to the same level. And the interstate travel picks up, but not as much, right? Because again, it was the larger states that had the initial infections. All right. So if I isolate top 10 states, that has pretty much no impact, right? Now, this is the mobility. There is some delays in moving to other states, you're seeing. But in terms of the infections and in terms of the deaths, it has no impact. So basically, mobility restrictions, either you have to do it completely or you don't do it at all, right? The partial thing, it has no effect. Now, what does it imply, right? This is now where we see so suppose it was the case when you completely block interstate mobility, it's a federal decision, whereas blocking the top 10 states, that's an internal decision. What you're seeing, blocking all states, the orange line compared to the no action line, it actually benefits the US somewhat. It benefits Maryland greatly, and it marginally harms New York, right? Because now the infection spreads much more rapidly in New York. That is the externality, okay? Of course, New York is going to oppose it, okay? Now, again, as I said, blocking the top 10 states pretty much has no effect because the other 7 states are going to spread it anyway. The economic outcome is actually the reverse. Blocking all interstate mobility hurts states like Maryland significantly. Number one is partially because they're smaller, right? Their options are, you really limited the options of the citizens of Maryland because they're stuck with a really, really small set of businesses. Remember, the N entered their utility function, right? It harms New York a little bit, and it harms the US a little bit more. But so Maryland is basically facing a choice, right? The trade-off between mortality, lower mortality, but lower economic outcome is much more severe of a really drastic action, is more obvious for uninfected small states. Okay. Now, Maryland might say, okay, we prefer just blocking the top 10 states. It doesn't really hurt us economically, but then it really doesn't have much benefit in terms of mortality. All right. Now, that was on the cost side of mobility, right? You are seeing clearly the externalities imposed by limiting mobility. Now, what happens if we close the businesses? So we look at the benefits of mobility. Now, here, what happens to New York, right? We closed half of all businesses in every state, but this is the mobility patterns in New York. It just shifts it a little bit. The low-risk people are, the interstate mobility is the same. They are less likely to now stay in New York, right? And they are more likely to stay at home. The high-risk people, their behavior in terms of staying home just shifts a little bit over time, right? It is not much of a difference for New York. For Maryland, it is also the same, right? Now everything is symmetric in all of the states. And this is for the US, what you're seeing when you close it, all of the businesses by 50%, right? Now the playing with the benefit side of mobility has symmetric outcomes in a way. The infections are flattened, pushed out a little bit, and the mortality rate goes down pretty much everywhere, right? Pretty much the same amount. So the severe externality is not as obvious in this case. Now, if you close it only in the top 10 states, now we have the exact opposite result, right? New York will close half of its businesses, but New Yorkers can go to Pennsylvania or they can go to Maryland and Virginia. So the mortality rate goes down. Their chances of getting infected goes down. Doesn't change anything in Maryland, and it has a small decline for the US. So closing businesses selectively benefits the high infection states, okay? And it lowers it flattens the curve here. So the externality works the opposite way. Now, if you look at it here, what it implies, so if I close all of the businesses in all states, you're seeing the orange line compared to the blue, orange bar compared to the blue bar, the impact is the same. But if I do selectively, I am benefiting New York and other high infection states at the expense of Maryland, right? The low infection states. Okay, because it makes Maryland more attractive for New Yorkers to come and spread the virus. In terms of economic outcome, right? New York is indifferent, but Maryland actually now is facing the trade-off again, right? You are seeing it here. Okay, actually, if you close the business in New York, all the New Yorkers come to Maryland, it benefits us because remember, they are getting some of the surplus. Businesses are open. So the Maryland legislature or the governor of Maryland is in a dilemma because whether they should support closing the businesses only in the high infection states or all in the whole country. Now, the final exercise we did was kind of try to construct kind of a possibilities frontier, economic outcome loss versus the mortality outcome, right? By changing the number of weeks. This is just closing half the businesses in every state. And you are seeing there's almost an optimal, right? You don't want to be in the top part, even if you look at the US. There's an optimal number of weeks where you should be closing the business. I think we're going to pursue this slightly more. And after that, closing the businesses much longer, 30 weeks, 40 weeks, doesn't really lower mortality, but it only comes at the cost of economic loss, right? So there's probably a sweet spot where the frontier, the trade-off happens much more sharply, and that's where the optimal decision is going to lie. All right. In terms of closing the top 10 business in top 10 states, that trade-off doesn't actually exist nationally, but it exists for New York. So the New Yorkers can decide where they want to be in terms of the trade-off. And Maryland is at the mercy of New York in that sense, but it has really no impact. All right. So I think this is it. I think I'm doing okay in terms of time. So the motivation behind this, as I said, is model the endogenous relationship between labor mobility and the spread of pandemic. So we can characterize the trade-off between economic gain from mobility and the health costs of the pandemic, right? Because mobility contributes to both the costs and the benefits here. What you're seeing, and all of this matters because there are two types of externalities. One is how the low-risk people are spreading it and putting the high-risk people in danger, but the local policies, right? If you assume the mobility restrictions are imposed at the state level, there are externalities or the business closures. And what I think where we want to get at further, and would appreciate your feedback there, the policy coordination at the federal level is critical. And that's part of the failure in the US we are seeing. It's not just necessarily the incompetence of the federal government, but also their hands are tied. Even if they wanted to impose certain restrictions, they might not be able to. And this applies, you can extend this to the global level, how the pandemic spread out of China to the rest of the world is an endogenous process. Okay. I think I am done. And these are the emails. The hard questions, as always, go to Erhan and Hey, and appreciate your time. Thank you.
Thanks a lot, Çağlar. And thanks a lot for your presentation. So now we have 15 minutes. So let me just add one comment, Çağlar, that is related to the question that I raised before. So to what extent do you think that your assumption that people immediately realize that they are infected matters? Because in a sense, the externality is even larger. You don't even realize that you can spread.
No, that's exactly right. So that's why, I don't know how much it'll change. For our purposes, it would introduce significant complexity, and I don't know what the benefit is. But what we did, our time period is 1 week. So within 1 week, you either realize, if you're showing symptoms. Now, of course, there are a lot of people who are completely asymptomatic, right? They don't even realize they caught it. And that's a problem. And we did not model that explicitly. But as you're seeing, in the absence of, like the low-risk people, and those are the asymptomatic people, right? The low-risk people are behaving as if nothing happened. The only thing that affects their decisions are not that they are infected or not, but it's the policy. So the whole policy intervention is designed to change the behavior of the low-risk people. The high-risk people are self-isolating, as you're seeing, even in the absence of policy restriction. So that gives us comfort, whether if you know you're infected or not, because even if you knew, is it going to change your behavior if you're not showing symptoms? If you're not showing severe symptoms? I don't know if that answers your question.
Got it. Thanks. So don't hesitate to jump in.
Simone, can I ask a question?
Sure. Go on, Michel.
Yeah, thank you. I like very much the paper. I think that one complication that what you are doing when you change the conditions, so before the pandemic and after the pandemic, and also when you introduce these scenarios, is that you are going to change very much basically the choice set of individuals in two different ways. So I just raised a question about the role of distance before the pandemic and after the pandemic. So when you have the pandemic, the role of distance is going to be boosted, because the further I'm going to travel, the more likely I'm going to be infected. So so this assumption of the constant elasticity of distance might be a little bit questioned. And the second point is that when suppose that you close the high infected states, and you said that these are the biggest states, then you change the choice set for these people from the state. So suppose that in New York, people had the habit of doing their business internally, okay? No, it's no longer possible. Then it means that you are going also to change the condition of choices. And then the substitution patterns between the different alternatives are going to matter a lot, okay? So I think that it's a little bit the complication of this type of analysis. I do not have a solution, but I just want to raise these points. Thank you.
So let me answer quickly, Michelle. I think, I mean, you're exactly right. So as you're seeing in the case of New York, again, this is, as you know, the first time we presented this paper, the model was much more simple with 3 identical symmetric states in terms of size. The only difference was one had infection and the other 2 didn't. So now here, it creates quite different dynamics when the initial infected states are the larger states. But you're exactly right in the following way. New York is a large state. Without the pandemic, New Yorkers stay in New York because there are more businesses, right? And same thing in California and same thing in Texas. When you close the businesses in New York, right, that actually benefits New York, right? Because that lowers the probability of infection. And it hurts the, as I said, the lower, so it changes the choice set. So that's the what we are trying to capture. So certain endogenous changes in the choice set are reflected in the optimization problem. Now, there is one thing we're not capturing, and I don't know how exactly to do that, and that's the following. I don't think the way the travel cost changes the following. The cost of driving from New York to Pennsylvania did not change pre or post-COVID. But what changed is the cost of flying. Right, a lot of flights were canceled, so the ability to travel from Texas to New York declined. We are kind of ignoring that, right? So you can interpret it as a policy intervention where you block travel from Texas to New York, but you can't block travel from New York to Pennsylvania.
Not
but
only
those
that,
again,
even with driving, I mean, if you had to go to California, so let's forget about the plane. I mean, if I'm going to Maryland, I can drive on my own in my own car. I can be protected. If I have to go to California by car, I have to stop maybe once, twice to stay overnight, and so on. So basically, the elasticity of distance is going to be much more important.
Believe it or not, I spent some time looking at the internal travel data we cited in the paper. There are very few people who drive long distance. If it is more than, I think, 8 hours of driving, majority of the people fly. So I am less concerned about, you know, how much you're going to catch because you're driving along the way. I mean, it might happen, but I think you're more likely to catch it at your destination. I am more concerned about what happens to the availability or the cost of flight, because it's almost 50-50 in the US. Interstate travel, 50% of it is driving and 50% is flight. So that we are assuming, you know, there were no cancellations in flight because, again, we wanted to, I mean, it's already a really complicated model and the calibration is tough. So we wanted to focus on the, you know, the change in the policy. But you're exactly right in the sense the overall qualitative feature is we want to capture how the endogenous changes in the choice sets affect the spread of the pandemic. And that's the idea here. And you're seeing heterogeneous impacts on the states depending on where they were in the pandemic and depending on their size. So here, the experience of Luxembourg in the European case, Luxembourg versus France, are going to be quite different, even just based on that. But I don't know if this answers your question.
Thank you. No. Thank you very much.
Frederick?
Yeah, so my question was a bit related to the previous one as well, about the length of the travel distances that people are covering. But when people are traveling for business reasons, I guess that usually they travel by plane. And you consider two very drastic policies here. So closing businesses or travel restrictions, while a third one, which may be less damaging economically speaking and avoid the spread of the virus, would be allowing people to travel, but put in place a large-scale testing policy. And this is basically what we have in Luxembourg as well. So it takes just a few hours to get the results. So you do a PCR test and 2 hours after, you know if you are infectious or not. So if you consider that people traveling by plane could be tested at the airport and wait 2 hours before having the results, I guess that many of the problems you identify could be solved, no?
Yeah, if that would be what the smart governments would do. But as you know, Like American Airlines just announced they're going to resume, you know, regular flights next week. And from people I know who have been flying, who had to fly, they're not really on many flights enforcing putting on masks. So you're exactly right. If you had some sort of a testing mechanism, you could do that. But remember, they can't even test people in the US who want to get tested, let alone doing mandatory testing. But you're right. I mean, that would actually solve quite a bit of the problem here. I think we can introduce it as, if you could identify who, yeah, that would actually solve a lot of the problems. I don't know how expensive it is and my concern on the feasibility given the experience of the US, but that would actually solve a lot of the problems.
So another question, you're not experimenting what has been done, for instance, here in France, where incomes were protected. So people were forced to stay at home, but their incentives to go out were lowered by the fact that they still got their salary. So
yeah,
do you think that would make sense?
Yes and no. See, we are looking at distributional outcomes, but you know, we have agents are homogeneous in the sense of their economic outcomes, right? Whether if you're high risk or low risk, if you match, you're drawing your random shock on the economic outcome from the same distribution, right? So there is no heterogeneity or inequality in that sense, right? That's an important dimension because what happened in the US, in Europe, in a lot of countries, it is the low-income people who actually have to go out, right? Their jobs cannot be done from home. And they are the ones who are getting hit economically. And so that would be like you could introduce another type into the model in a sense of the low-risk people, of the low-risk and low-income and high-income, where the high-income can subsidize the low-income people, right? To encourage them to stay home. Here, it doesn't matter because everybody is identical. So who's going to pay for it? You have to take the money from everybody to give it to everybody. And we don't have an intertemporal borrowing mechanism for the government in that sense, right? We didn't assume that. But that's an important distinction, this whole, you know, the income level issue, whether if your job can be done. We assume that away. We assume economically everybody's homogeneous. The heterogeneity exists on the health risk because we wanted to capture that externality. But that's an important extension. Maybe the next time around, we can introduce that.
Okay, thanks a lot. So are there further questions for Çağlar, Erhan, and He? Çağlar, can I just, while I see whether more people want to ask questions, can you just interrupt your screen share so that I can share mine? Just
sure.
to get a lot of information.
Yeah.
Okay, thanks a lot.
Is it gone?
Yeah.
Okay.
So, okay, I'm not finding my my file. So let me just speak. And so we are resuming our seminars after the summer break on September 9. So the first presentation is going to be Sandra Rosso from University of Southern California, Marshall, and then Anne-Sophie Beck-Knudsen from Harvard on September 16. And further dates will be added down the road and will be advertised on our website and via our mailing list. But there's still the junior seminar going on a bit more. So there's the last session before the summer break on July 13. So you're more than welcome to join. Again, the information is available online and spread via our mailing list. This is the last senior seminar before the break. It was very intense, 2 months and a half. So more than 10 seminars, a lot of exchanges, and we are all convinced that this is gonna be maintained, even if, as we all hoped, the situation will improve on everywhere in the US and Europe and elsewhere in the world. But we're gonna keep on at least for a few more months, and then we will try to make up our minds. So, are there further questions about the presentation today? Okay, then.
One remark, Simone. I just want to thank you on behalf of all the organizers of this seminars. You've been instrumental instrumental to initiating, organizing, you know, putting the infrastructure in place. So thank you very, very much for that. And
thank you. No, you're welcome. It was really my pleasure, and it was the way to find a bit of intellectual freedom while we were all locked down at home. So this was truly very, very valuable from both intellectual but even a psychological perspective. Being friendly faces around and exchanging ideas is really great and vital for all of us. So thanks to all of you, and we will see each other after the summer break.
Bye bye. Molto bene, Simone. Bye bye.
Grazie, Michelle.
Yes, thank you, everybody.
And Çağlar, I'll see you in a meeting right now. Bye.
Yeah. All right.